Hey, Corey. Oh, hold on. We had to have a little change of venue because apparently there was an exam going on that I didn't know about. So I quick got everybody into a different room, but we got you all set up. So I'll do introductions in a sec if you're
No
good.
problem. No problem. Did everyone have that like moment of panic where you thought like it was your exam?
No, I think I was the only one that had a moment of panic where it was like, oh, wow, I screwed up. But
It happens.
no, see, we do 4 exams straight and we don't have a final. So I like to think
Excellent.
I'm an awesome teacher for that.
You're so cool.
I try real hard. All right, so let me do one thing real quick. So I will, instead of looking at me, I will just kind of look at everybody.
Okie doke. I was going to say, please tell me I'm not like massively large on a big screen, am I?
Not massively large, large as you need. So I will do quick intros for everybody here. So I guess we have most people, and if anybody else, I guess, is coming in, they'll join. So for all of you guys, so Cori, you are our last sort of presentation of the semester. We brought in different people to kind of talk about various things. We had a friend of mine who's a doctor of neurology at Jefferson talk about research. We've had people come in to talk about addictions and eating disorders and various things that are relevant, cancer survivors, but things that I couldn't necessarily talk about. So, for you, one of the reasons why I appreciate this so much is because although we were in class together, Corey and I were in our PsyD class together, and while we learned the same things at that level, you went on to do something with it. So you bring a totally different perspective, and I think something that sometimes can get a little lost. So that's why I love being able to introduce you to these guys in case, it may trigger something that they enjoy or want
Sure.
to do for a living, or even just if they have some questions. And then for you guys, we have Dr. Cori McMahon, who, like I said, graduated with me at LaSalle University. And she has quite a list of accomplishments to her name. She was the previous director of the Cooper Behavioral Medicine School at Cooper University, if I'm getting that right, or the training program at Cooper.
Yep.
Now the VP of Clinical Services at Tritium. And she is just the overall guru of everything health psych related as a health psychologist. So I will turn it over to Cori to kind of do her thing, and I think she has some stuff to share with you as well. And then I will just
Yeah.
become a member of the class.
Awesome. Thanks, Jeff. Yeah, I'm glad to join all of you today. And I always enjoy being in the classroom. I'd actually prefer to be there with you physically. It just wasn't working out for me to get quite that far today. So I'm glad I can Zoom in. Can I just get by a quick show of hands? I think I can see the majority of you sitting in there. How many of you are psychology majors? One. Do I see one? Like I'm old and my eyesight is not awesome, but I think I see one.
Three.
Three. Okay, there are a couple up front I probably can't just see. All right. And others, are there allied health, nursing, social work? Can we get okay, I see other hands going up. Because I'm always interested in, who from different majors are taking a course in health psych and trying to understand what it's all about. And it's awesome because the world of the health psychologist, as I'll share with you in a few moments here, is not a solo practice world. You might think of, psychologists who work in private practice as oftentimes, working kind of alone. Health psychologists are quite the opposite. We work hand in hand with social workers, with physicians, with nurses, with caseworkers, et cetera, et cetera. So the practice of health psych really does require us to be collaborative with different professionals because we are understanding the patient from all different angles. So I am going to show you, hopefully not bore you but show you some slides because I think it helps kind of keep me on point with kind of career trajectory and, what is a health psychologist? How do you get there? How did I personally get there? And what the heck am I doing with it now? So give me 1 second. I tried to shut down all my other stuff so you wouldn't see all of my Slacks and emails and stuff coming in. So don't you hate it when that happens? Okay, you already know me. So as you guys have probably been talking about all semester, there are lots of different career paths in psychology in general. You're probably talking more in the health psych world, but kind of on the left-hand side there, folks who go into psychology end up finding themselves in a few different main buckets that they might be interested in. Maybe they're, fully doing research and can be, heavily focused in research. And oftentimes we joke and say that's a research silo, people who are doing like mostly academic research. Those who find themselves in academics really are teaching largely, and often will do some research, but largely teaching. IO Psych, I'm sure you're aware, I'm talking to a college level group, but industrial organizational psych is definitely a thing unto itself. And those are psychologists who work in the business world and help with things like mergers and acquisitions and executive coaching and things like that. By the way, they charge just about as much an hour as attorneys do. So, food for thought there. And clinical psych on the bottom right-hand side there. Clinical psych is very diverse. And people who go into clinical psych, as you can see, broken down a little bit there. I just broke down a few kind of major buckets, but there are so many specific specialties within clinical psychology, it wouldn't necessarily fit on a slide. But some people are interested specifically in pediatric psych or child and family psych in general. So those psychologists who are taking patients in private practice or group practices and see lots of different types of patients. I have a number of colleagues who work specifically in sports and performance psychology. Very cool, and are working with elite athletes on their performance, on performance anxiety, on how to handle injuries, how to handle the pressure of that high level, performance world. And then health psych, I put on the bottom. And for all intents and purposes, health psychologists are most often working in a medical field or very closely adjacent to a medical field. So I kind of put this quick slide together to understand what exactly is health psych. You already know this, you're near the end of your semester, but health psychologists understand patients from a biopsychosocial model, bio being the medical side, genetics, genetic components and things like that. Psycho being psychological, that's mental health and behavioral health. Have you guys made a distinction in your class? What is mental health versus behavioral health? I think those terms are used interchangeably pretty often, but is anyone willing to go ahead and give me your definition of the two or the difference between the two? Jeff can call on you if you ask.
You put me on the spot to call, so okay then.
Yeah.
You're one of my go-to.
It's not really a wrong answer here. It's just that
I guess mental health would be more like what's going on in your brain versus behavioral health is like what you actually physically do.
yeah, absolutely perfect. I think behavioral health as a term usually gets used as the umbrella term to include everything. But when you're in the field, we do kind of mean different things, and often, and you're absolutely right. Mental health, mood functioning, etc., and behavioral health, the actual behaviors that are manifesting, completely connected, of course, right? But when we're talking about things like health related behaviors like smoking and physical activity and things like that, that would fall under that behavioral health term. And then social, so the social part of the biopsychosocial model, things like social determinants of health. Huge buzz term in the world of health psych, thank goodness. We're finally coming to a realization as a society that people's housing and housing security, food security, stress in the environment, actual health of the environment, education level, transportation, all of those things actually have a real and significant impact on mental health, on physical health, et cetera. And cultural impact. So a health psychologist does understand a patient from all of these different angles and looks to intervene where necessary to make improvements for the patient. Let me see. There we go. Where do health psychologists work? It sounds like you've had some different speakers throughout this semester. So you might have had folks who are working in different areas, but I kind of made a quick list, and health psychologists do a lot of cool stuff. They certainly work in private practice. I do have a colleague who works in private practice who's become pretty popular on Instagram, and Fox News calls her up for little spots and things, but she does focus in working with women who are going through breast cancer, for example. So she has become known in that area. They work in a hospital or healthcare system. I have done that for the last 14 years. And I'll give you a little more detail about that in just a moment. They work in integrated primary care. You'll hear that term a lot, integrated primary care. And that really exists on a continuum. Some organizations will say they have integrated care, but there's no behavioral health person, located immediately on premises, but they do refer patients to behavioral health care. So that's cool. That's a first step. But truly integrated care is where mental health professionals and medical professionals are working side by side for the health and wellness of the patient population. They certainly work in universities, government agencies around policy, which I think is really cool. I think in the last, I don't think we can have a conversation without talking about COVID, right? So in the last 2.5 years or so, one of the silver linings of this awful experience is that mental health has come to the forefront as something that we actually realize is important. And as all of us, including the normally well-functioning subset of the population, has experienced pretty extreme stress, there's finally a little bit more attention paid to mental health. So psychologists are being asked to do a lot more things, including weighing in on public policy, than we have done in the past. Health psychologists work in the corporate world and industry. And my life actually is currently split between working in industry and working in a healthcare system, which I'll share in a few minutes, exactly what I do in industry and what does that mean. And then some work in specialty care, including especially places like oncology, which is cancer care, cardiology, pain management, rehab, bariatrics. So I don't know how familiar you are with the process of going through bariatric and metabolic surgery. So folks who are looking for significant weight loss support, it's required that you have a psych eval done as a part of your preparation for surgery, and psychologists have to do those. My team did those for a couple of years at Cooper. It's really an interesting process, and then helping people on their weight loss journey after surgery, pediatrics, trauma, et cetera. So lots of different places that health psychologists can work and share their expertise. So what exactly do we do in all of those places? I think at a very high level, right? Because it's pretty specific what we do in all those different places, but at a very high level, we understand that there is a reciprocal relationship between physical illness or wellness and psychological functioning. When people ask me, what exactly do you do at the hospital? I say, well, high level, I address all of the psychological sequelae of being diagnosed, of going through multiple health issues, of experiencing a traumatic injury, et cetera. And reciprocal meaning emotional, psychological health impacts physical wellness, and physical wellness impacts psychological health. Obviously, they go hand in hand. They're all in the same person. So we have to address both at the same time in order to help people get better. We use a lot of psychological research and methods to the prevention and management of disease, and of course, promoting health behaviors. So we do things like helping with smoking cessation, helping people who are looking to improve diet and exercise, helping patients adhere to medical regimens. So folks who are experiencing chronic disease management like diabetes, HIV care, things like that. Health psychologists are a pretty active part of helping people stay on their insulin as necessary, take their ART meds, antiretroviral therapy, ART, for HIV, stay healthy, things like that. We work to improve the healthcare system. So there are lots of different ways that we do that. In the instance of my team, which is behavioral medicine at the hospital at Cooper, I would say 50% of what we do is work directly with a patient. And the other 50% of what we do is educate physicians and other staff on the patient and their challenges, their behaviors that are being observed, et cetera. So we can really serve a patient well if their doctor better understands them. I'm sure that makes sense to you. And we can also support the medical staff. So especially during COVID, we have made a major pivot to providing kind of brief supportive meetings for different departments across the hospital system. As you can imagine, and as you've seen on TV, or maybe you have people in your own lives who work in healthcare, going through COVID has been nothing short of devastating for a lot of healthcare workers. And so one thing that we can do by, in order to improve the health system is to make sure that that those who are providing care to patients are also getting the support that they need. We inform health policy, like I mentioned, so more and more psychologists are getting, I wouldn't say getting into politics. I don't know many psychologists who would be interested in getting into politics. We're too smart for that. But I think able to be a part of government agencies and advocacy groups. So the American Psychological Association, which is a huge group nationally, the Society of Behavioral Medicine, which is the professional group that I belong to, all have advocacy groups. So we get to kind of weigh in on campaigns where we're sending emails to our local senators and things like that.
I don't know. I think maybe it's time for a psychologist to run for president.
I know, right? I mean, I would argue that the world would be a much better place if a psychologist were in charge, but yeah, I'm not interested. I don't know about you, Jeff.
No, I'm good. I'm good.
Yeah. No, thanks.
Than I am, so.
Goodness. But yes, I completely agree. I think, or at least have, we've got this entire cabinet of professionals, right, who consistently guide and inform our president. But there's no mental health professional on that cabinet. So maybe that's a change that could actually happen and make some impact. We've got the US Surgeon General, who's never even been a psychiatrist, let alone a psychologist. So and then we use a public health perspective. So when we're thinking about even the work we do with, one patient or one type of group of patients, we think about larger impact. So in the work that I do, again, I'll kind of get there in just a minute with patients. I work in an integrated primary care setting that serves the HIV population. We're consistently thinking about not only how we're handling, the psychological stress or distress or challenges of one patient, but we're also thinking about viral load suppression. And that means keeping HIV to a suppressed level so that it can be shared with someone else. So if someone is virally suppressed, they can't give HIV to someone else. So you can see how that very quickly becomes a public health issue. And this is where, there's a huge ability for a psychologist to make an impact at a public health level. So what does it take to get there? I don't know, Jeff, have you talked a little bit about this, kind of the road to?
We really haven't yet.
Okay.
Yeah,
I don't want to be boring and redundant if you have.
For people, so.
Okay. So for those of you who are interested or think about, going into health psych in general, health psychologists generally have doctoral degrees, and that, to add it up here, there's the obvious, which is the 4 years of your bachelor's degree, which does not have to be in psychology, by the way. Master's degree programs are 2 to 3 years, depending upon, the school and the program that you're looking at. But the doctoral degree, which is a PsyD or a PhD, is a 5-year program. However, the master's degree can happen within, excuse me. So that doesn't have to really be, 7 to 8 years. That could be 5 years total. Really depends upon the experience that you're bringing into a doctoral degree. And then I put, all those asterisks there because there's clinical experience that you get along the way. When you're training in a master's degree and a doctoral degree, you spend, you do part-time jobs for which you do not get paid money, but you get paid great experience. Then you're doing your clinical rotations, usually 2 to 3 of those during your doctoral degree, and then a full-time internship the 5th year of your doctoral degree. And then most people, well, you need to do there after you've graduated what's called a postdoctoral fellowship, which is where you're really starting to specialize. You're going to take a fellowship, which is basically a job where you're getting supervision and you're counting your hours toward being eligible to take the licensing exam. And different states are different. For example, in New York State, you can take that exam I have listed there, the EPPP. You can take that immediately upon graduation. But in New Jersey, you have to complete a certain number of postdoctoral hours before you can sit for that exam. Same for Pennsylvania. And then you have to take state law exams as well, which are usually like 30 questions, multiple choice. You're really just memorizing the laws as they pertain to the practice of psychology. So if any of you are going like, oh my God, no, thank you, that takes forever. The only thing I would say is you're going to go ahead and live your life regardless. So make sure that you're doing what you want while you're moving along in life. Does anyone have any questions or comments before I move along? Health psych in general, programs in the Philadelphia area. There are a number of really great doctoral programs in health psych in Philadelphia. Nope. Okay. So I figured I would just give you a little bit on exactly how I got myself where I am and what I do. So as Jeff mentioned, we went to LaSalle together, but I did get my bachelor's degree in psychology. And while I was an undergrad, I actually, during my senior year, I did an internship at Friends Hospital. So if you haven't heard of Friends Hospital, it's in Philly on the Boulevard, and it's the oldest psychiatric hospital in the country. So it's a very cool place to work if you ever had the opportunity even to visit. And I was what was called at the time a psychotherapist there, which is interesting because I was not qualified to be called that. But basically, I was doing intake evaluations in their crisis response center, and that is a psychiatric emergency. So that was really, really great experience. I did both my master's degree and PsyD degree at LaSalle, and clinical time included time at our counseling center on campus. So my first clinical experience was working with college students. Which was great and gave me more diverse experience than I thought it would, and kind of weird because I was just graduated from college and working with college students and living on campus and seeing college students who I was working with, and interesting and really a great lesson in professional boundaries and things like that. And then during my doctoral degree, which is there in the middle in the purple, 2003, I did a couple of clinical experiences, one at Northwestern Human Services, which is community mental health, which also gives a great kind of breadth of experience because I think my youngest patient at the time was 4 years old. My oldest was in her 70s. And I was able to work with everything from folks who had substance use disorder challenges to folks with pretty severe experiences with psychosis, schizophrenia, et cetera. So really great experience in community mental health because it gives you a nice wide variety. And then I also did an internship at LaSalle, which is in the outpatient psychological services, while I was also teaching at that time some undergrad courses and supervising some master students in the work that they were doing. And then 2 postdoctoral fellowships. So my first postdoctoral fellowship was in child and adolescent psychology at a place called Community Treatment Solutions. And I took that job for a couple of reasons. One, the obvious, I needed money because I was graduating from college and, actually had to have a paycheck. I needed health insurance. And this job provided me 2 things that I really needed otherwise. Supervision for my clinical hours and filling a hole in my experience. So I hadn't had a lot of experience with young patients, and I wanted to be able to fill that gap and kind of broaden my horizons with children and adolescents. So I was working with children in the foster care system and adolescents who were court adjudicated. Very interesting. I did that work for 2 years. And all the while, so you haven't heard anything yet about health psychology. because health psych at the time was, when I was in school, because now I'm 800 years old, was not a kind of very common training track in graduate programs. So I took all the courses, which we had in our doctoral program. We had health psychology 1, health psychology 2, we had rehabilitation psych, neuropsych testing, all of those things that get you prepared to be a health psychologist, but we didn't have a formal track. So I took a second postdoctoral fellowship in behavioral medicine at the UMDNJ, so it's University of Medicine and Dentistry of New Jersey, which was combined with Cooper Hospital, which is how I kind of got my foot in the door to work at Cooper Hospital, where I've now been since 2008. And the kind of job trajectory, I guess, includes that first out of grad school job that I noted with, which is CTS, Community Treatment Solutions, there on the far left. It was a really good and interesting experience and did give me that direct care with kids and adolescents. I would say it was great to jump in with both feet with that population, because this is a population of kids in the foster care system, largely who had pretty significant backgrounds for trauma, histories of sexual abuse, current substance use for some of them, even though they were quite young, and violent behavior, et cetera. So it was really a great experience to kind of broaden my horizons with younger patients. I have taught at LaSalle for a long time, intend to teach the same courses, psychological testing and assessment. I taught human sexuality for about 10 years, which is always interesting. And this might sit well with all of you because of the school you're at. You're also at a Catholic university. I tend to get myself in trouble when I'd have different speakers come in the human sexuality course, folks coming from Planned Parenthood and things like that. Because my argument was I was coming from a psychological and scientific perspective, so I needed folks to know everything.
More jarring than the person that we had in our master's program, though, if you recall.
Who was that?
I can't remember his name, but I remember like the final day was going into his office, and
Oh, was that Bill Staten?
yeah, I think so. That was
Yes.
very
And we had these sexual attitude reassignment project.
Mhm.
Yes, I think he probably helped desensitize me for the work I was to do in the future.
Yeah.
So yes, for undergrads, I didn't go that far and didn't feel qualified to. But I did certainly have folks come in and demonstrate, proper condom use and things like that. And Brother Burke, who at the time was the head of the psychology department, basically said, I am supportive of this, but please don't say it out loud anywhere on campus because we'll both get in trouble. But it was good. It was good. But yes, that sexual attitude reassignment was very interesting. And I think really great for someone who's going into clinical psych, let alone clinical health psych. Little did I know I was going to spend a whole bunch of my career talking with people about sexual functioning. I did for about 10 years working in cancer, where sexual functioning is like terribly assaulted by surgery that people go through. And then again, I've worked in the HIV population for a long time. So it's safe to say that, sex, sexual functioning and relationships is on topic pretty regularly. Let me see, I've also taught courses at Rowan for years, and I don't currently, but I am still on a bunch of dissertation committees and things like that. But the two areas where my life remains is at Cooper Hospital. I'm the former director of the behavioral medicine program. About 5 years ago, I decided to quit doing that work full time. I keep it part time because I wanted to jump into industry. Meaning the business world. And I decided to do some work with a company I was familiar with because I was doing some research with them. They were using some of my patients at the hospital for different projects and things. Tritium is a behavioral health technology company. It is a SaaS-based, so software as a service based company. And we work with health systems, insurance companies, large behavioral health organizations all over the country, to help them best assess their patient population for psychological needs, get patients connected with the best behavioral health provider for them. And then they use us for measurement-based care, which means assessing a patient at every session in order to make the best of their psychotherapy course. And what I do there is, oddly enough, I work a lot in sales. I never thought I would be like a salesperson. And I'm not in the sense that I'm kind of, talking about contracts and prices and things like that, but I'm kind of like the covert salesperson, whereas I show up as the subject matter expert. I talk about the platform and how, a hospital system can use the Tritium platform to their best benefit. I worked with the product group within Tritium because as a provider, I understand patients and their needs. And I certainly understand what behavioral health providers want for their from their software. I work a lot with our research team, mostly to help research translate what the data needs, what stories the data needs to tell. And we use data a lot for marketing purposes, as well as doing projects with our customers. And then I do a lot of consulting. I do consulting internally. And I do consulting with organizations who are trying to do things like integrate behavioral health into their services. At Cooper, I still see patients. I mentioned I work in a clinic that serves the HIV population. I supervise doctoral students, so PsyD and PhD students, usually from LaSalle, from Drexel, from PCOM, some on occasion from Temple or others, Lehigh sometimes. Who are working with us to see patients. And then I teach a couple courses in the medical school as well. And I do own a private practice, but based on the other couple of things I do, I have no time to do anything with it. So it's just, cool that it's there, and maybe I'll use it someday. And I'm actually sit on a panel with CMS. That's the Center for Medicare and Medicaid Services for the federal government. And it's a neat quarterly meeting where CMS is trying to always improve upon their outreach toward their, what they call members. So all of the folks who take Medicare in our country or Medicaid as an insurance, all of the outreach and education that they do, they run it by this panel, and we get to weigh in on the kind of work that they're doing and wording and graphics and all kinds of things. So it's pretty cool. And I think that's it. Yeah. So I'll stop sharing and see if you actually have any questions or if you're sleeping or whatever.
So this is a good chance for you guys to, if you do have any thoughts about either any of the things that we talked about this semester, or about the career, or about, even just kind of like what was the most challenging part of Cori's job, or something like that. I know I, for one, would struggle working with people who are going through physical treatment. And I know one of the things that Cori loved doing was working with people with cancer. And I don't think I could have done it. I think I might have really struggled. So, everybody kind of has a different world of things, that different comfort levels, different passions and stuff like that. And it's really neat that but there is somebody for every kind of subspecialty and passion and whatnot. So I know we did have a couple people in here. We had 3 cancer survivors come in to speak. And it was pretty interesting because we had, I think you may actually know TJ Sharp.
I sure do.
Yes, yeah.
Yeah.
I guess both, yeah, because he was local to South Jersey before he moved to Florida. So he talked.
Yep. I know TJ because we went to high school together.
Oh my gosh, how about that?
Yeah.
That's right. I remember
Yep.
that.
I
Yes.
cheered for him when he played on the football team.
Wow. That's so
Yep.
funny.
He's a great guy.
So he spoke
Cool.
about his melanoma diagnosis, and we had a friend of mine who's been breast cancer free for 15 years, and somebody who just recently got her all clear. So, we tried to kind of talk from different angles, and about the importance of social support was a big part of what we talked about.
Yeah.
So like, I don't know, maybe you could sort of talk about what would the role be when you're working with patients and families in
Mhm.
such a difficult thing. I mean, and maybe even when you're talking about uh, inoperable things, terminal
Yeah.
patients. How do you kind of function with that?
Yeah, that's the great question and great kind of thoughts along there as well. And to your first point about I think you said something along the lines of I'm not sure I could do that, right? Work in cancer. And you're right. So I think when people students who come through and work directly in oncology with us, I think you realize pretty quickly that it's either for you or it's the opposite, and you're like running from the building as though it's on fire. So it's definitely one of those things that it's if it's for you, then it's really, really an amazing experience. My first comment is always that I feel so appreciative and fortunate and blessed, if you will, that people who are going through cancer were willing to spend time with me. Time is so incredibly precious as it is. And when you're going through cancer treatment, you really, really very intimately feel how precious time is. And I would say that the work that one does, a health psychologist does in oncology, seems to be, well, it's incredibly important, number one, but it seems to kind of ebb and flow. So I would say the majority of my patient caseload over those 10 years I worked in cancer would either be new diagnosis, hopefully for obvious reasons, right? It's completely overwhelming. Usually when people hear the words, you have cancer, it translates in their brain to you are going to die. So there's quite a lot of processing that needs to happen in order, for that person to be able to kind of step forward in their treatment and make sense of it. And having symptoms of depression and anxiety at that time is completely normal. And yet it doesn't feel normal to the person. So, having a guide on the kind of psychological and emotional side is really helpful. And then in the middle of treatment, whether someone is going through chemo or preparing for surgery or both, going through radiation, there's so many different challenges that come up that that the psychologist ends up kind of more kind of acutely being involved in, maybe not steadily. I have prepared people to go into gamma knife surgery, which is a brain surgery. It's kind of a Star Wars-like experience. The whole thing is intimidating. So some of that is just helping manage anxiety and expectations, helping with a lot of education. I have sat by chemotherapy chairs for months on end as people are trying to kind of go through the really outward and obvious signs of cancer treatment, which is hair loss, oftentimes weight loss, and other challenges to to body image. And I think that concept body image sounds like, oh, it's about aesthetics of your body. And yes, that's part of it. But in the world of cancer, it's also about body functioning, not being able to do things as you used to be able to do, not feeling like yourself, not looking like yourself. So there's a lot of that work. Post-surgical, there's a lot of work as well, kind of getting back on your feet. And then I have, to the point about whether or not cancer work is for you, certainly work with people in the death and dying process also. So to Jeff's last kind of comment or question, what is it like to work with people when something is not curable, not operable? I have absolutely been a part of family conversations around hospice when it's time to make that decision to go to hospice, and work with patients in preparation for their own death. So for some people, your response might be like, oh my God, that's so morbid, depressing. And the answer is, yeah, of course it is. And it is real life. So if I can be supportive to someone while they're going through it, then that is amazing. Again, what a gift. And there's something called legacy work. So when someone, is potentially or definitely facing their own death and dying process, there's some really cool work that can be done that can feel very meaningful, especially if they're kind of trying to process leaving people behind. So the one example I'll give of that, and there are lots of examples of legacy work, which we don't have to go into unless you're really interested, but is one woman I was working with as she was probably the last like 2-3 months before she passed. We worked on what she termed a mom SOP, Mom's Standard Operating Procedure Manual. And we put together this manual because not unlike, I hate to stereotype, but not unlike a lot of women, she kind of took care of everything in her home. And she had 2 boys, one in high school, one just starting college. And she wanted to make sure that her husband and her boys were armed with all of the information that they needed to take care of the house and to get the next one into college and, all those things. So she wrote up this like standard operating procedure manual, of course, with lots of, comments and jokes and things that she wanted to share with them for after she was gone. So felt really meaningful and actually had her feeling, a little bit more at peace with her passing. So really, like I said, a gift and not easy work either.
Oh, you should have had that. The family should have had that published because that sounds amazing.
Yeah.
And B, it actually makes me think I should make an effort for one of these classes to try to have somebody on the other side of the fence speak, somebody that was part of a family who worked with a health psychologist, because I would imagine that it made a huge difference having the preparation and not feeling alone. So that was an interesting perspective. I'll have to think about.
I hope so. I like to think that. I think, that example comes up to me, of course, first, and then another, again, it's all called legacy work, but another that comes up for me is, especially for folks who have young kids. And of course, all of the loss and all of the grief, the pre-grieving that happens when someone knows that they're dying and they're going to miss their children's lives, is we would put together either like video recordings or handwritten or typed things, or even cards, where the person, the patient, would write in either notes on like hot topics. We'd come up with a list of topics. If you were going to be there in your kid's life, right, you would weigh in on things like your first kiss, on things like, what does mom feel about like getting a tattoo, like all the hot topics, right, in life. What does mom think about, alcohol, prom night, all of these different important milestones and topics and things that are really important to a parent to be able to share with their child, their perspective, right? So we would kind of write up or video record, kind of little snippets on those things so that child, as they grew, could have that. So really neat stuff. Again, not very easy and so incredibly valuable. So if it's for you, it really does make a difference for people.
Yeah, absolutely. What else, guys? So that was an amazing question that I asked.
High five to Jeff. I would say one thing that might be helpful is to kind of put in perspective, since there are a couple of psych majors, but also other allied health or nursing or others, is the way that health psychologists kind of work in tandem with other professionals. It's definitely a collaborative effort. In my work at the clinic where I have been now, I've been there since 2014, I think, is that I literally sit in the provider workroom with the HIV care, the infectious disease docs who do HIV care, with the primary care docs, with the nurses, with the addictions counselor, with the addictions med providers, which is Suboxone treatment for opiate use, with the pharmacist. So we're all literally in the same physical space. And therefore we get to hear conversations and jump in on them and, just say the primary care doc just saw the patient and said, here's what I'm seeing. And the patient's not taking their meds regularly. I don't understand, A, B, and C. They're presenting as depressed, or they're presenting as anxious, et cetera, et cetera. So we can then discuss, I can throw out a few hypotheses, I can ask more questions. And oftentimes I am then the next one going in the room to do an assessment. So it's very kind of quick. They're called warm handoffs. Doctor needs some questions answered. Patient needs some support, and now I'm a part of the medical team as well. So there's a lot of that kind of very hand in hand. Your medical work is just as important as your nursing care, is just as important as my psychological work. So it really is treating the patient from all angles and giving them all the support they need, and it does make a difference.
So that actually makes me wonder, and I think this is a question that could probably pertain to everybody, both, regardless of what your professions are, or if you have nothing to do with the care world at all. What happens if you, as a subscriber, as a patient, or as a probably even more so as a caretaker to a patient, somebody that's got a pretty large team. So you have somebody that sees OT, and they see a psychiatrist, and they see a psychologist, and they have another specialist, and then they see an endocrinologist, and there's no there is no integration. Let's say, because I've seen this both professionally and personally, and have thought, hey, I kind of wish everybody was talking to each other. And I would think a health psychologist would be a place where that would come together. But what if that's not available? Is there a way to advocate for that? Is there what do you do in that case as a patient?
Yeah, that is difficult and not uncommon scenario. So I'm lucky I work in an academic health center where the majority of our patients who, come into our clinic or even elsewhere in the system, all of their medical providers are usually within the system. So I can see all the providers' notes. I can communicate with all the providers on the team, and they can see mine, which is kind of where that integration comes. And that's not true everywhere, right? You might have a primary care doc who's a part of an independent practice. And like Jeff mentioned, you're also seeing a psychiatrist somewhere, seeing a counselor somewhere. It's really difficult. And unfortunately, the onus ends up landing on the patient to advocate for themselves and try to make those connections. I think, and I know that most often the mental health provider, or if there's a caseworker or social worker involved for any reason, usually in primary care, they would be willing to help support all of that collaboration. Just that the patient would have to be willing to sign releases to make sure that information is shared. And I think sometimes people get nervous. I don't want my information shared. I want to keep, my mental health work private and with my psychiatrist or my psychologist. And I understand, because it's so sensitive and personal. And keeping it separate from the rest of your medical providers is doing no one any good. So I think it's important for our primary care docs and for our mental health providers to make sure that we're constantly educating people that hey, who else is in your care team? Who else do you see? I would love to be able to communicate with those people, and here's why. Because there's so much more to you than just the work that we do together. And so a lot of providers don't kind of share that holistic view. Therefore, patients aren't able to appreciate it and wouldn't really think of, making sure that everyone's talking. And it's hard.
I'm looking longingly, or I shouldn't say longingly, expectingly at my students. Go free in the back. We have a question.
Earlier you were talking about working with mental health in regards to people in the health setting, the professionals in the health setting. Can you think more about what that kind of looks like as you lead a group or something that of medical professionals?
Yeah, for sure. I'll say two things about that. First, kind of on a more global scale, it's finally being recognized that that healthcare professionals need attention to their own wellness. So hospital systems across the country have historically had, oh sure, we have human resources, or we have what's called an EAP, which is employee assistance program within the organization, which is, you can get some counseling if you need it. So that's always kind of been there, but not really been a focus and not really been a great resource. But they're making a nice shift to, instead of just employee counseling to employee wellness programs. So there's a little bit more of a focus now on employee health and wellness in large hospital systems, and exactly what does that mean? And it's not just about putting out a fire once it's occurred. It's not just about waiting until someone is, God forbid, suicidal. I know that during COVID, we've had some, prominent physician suicides across the country. It's not just about waiting for burnout, right? It's about kind of trying to be preventive and look at kind of stress reduction. I don't ever want to say that the words work-life balance for medical providers, because it's not a thing. But making sure that people are getting appropriate support, peer support and other. But the work that we ended up doing, and again, it was prompted by COVID. So some of the silver lining on this like awful, global experience is it was recognized pretty quickly that especially the frontline nursing staff, the frontline medical staff on our COVID units, in the emergency department, et cetera, were really feeling the stress. No surprise, right? They were literally witnessing people dying and had all those horrible things. If you guys aren't like immediately next to it or have healthcare workers in your families, I can truly tell you that those stories are real, right? Nurses having to hold up a cell phone while someone was dying so that they could talk to their family members. All of that was happening. So our hospital administrators were kind of like, oh, good God, what do we do? Like, we have nurses in the administrative office crying. We have people, wanting to quit. We have, people in significant distress, and we need them well enough to care for the patients. So they called our team and our current director, who's my dear colleague, Dr. Gilrain, and said, like, can you guys do something? I think it was one of those desperate kind of outreaches. Well, you guys are all the psychologists, and I know you work with our patients, but like, our staff is having a hard time. So we put together what we ended up calling the Resiliency Response Team, the RRT. And that was our team, which is behavioral medicine, but we also elicited the support of folks in psychiatry and different clinical social workers across the system, and a couple of psychiatric nurses as well. So we kind of made this larger team, and we literally got a schedule together. And thank goodness we got some administrative support, because none of us have time to like make schedules and appointments and things. And we, like, two of us got grouped together at a time and got sent to work with different departments. And like, for example, on a given day, again, this is like in the beginning of COVID when, like the world was still mostly shut down, but hospitals were not shut down, of course. I think in one day I spent time with a colleague running a group, and I'll tell you more about the group in a second, but with the entire phlebotomy team in the hospital. So the folks who draw blood for labs. And we also worked with the food service team that day, which is completely different, right? They're the people who are, are delivering and packaging food, both in our cafeteria and on the floors. And then we also worked with the emergency department physicians. So like, such a diverse group of people in one day. And each one of those groups was around kind of understanding that the stress of the situation is normal, because the situation itself was very abnormal. Global pandemic just fell down on all of us, and kind of looking out for what could the signs of distress be, how to manage that stress. We taught some mindfulness-based techniques, and we allowed very kind of safe space for sharing real fears. And I can tell you, interestingly, again, talking with phlebotomists, people who draw blood, talking with food service workers, and talking with ER docs all in the same day, I heard the same thing from all of those people. And the thing was, I'm not as afraid that I'll get COVID, although that's pretty scary. I'm mostly afraid that I'll get it and I'll take it home to my kids, my family. Some of them were like staying in hotels for weeks on end for that exact reason. So there was so much that was going on, but they were really awesome and really effective, like 30 to 45-minute meetings that we kept up pretty routinely for those first like 6 months or so. And then we kind of backed off a little bit and allowed those departments to actually sign up if they wanted to. At first, it was like forced. They had to meet with us. But it was really helpful, and it got people talking, especially in the world of the medical physician who is supposed to be a caretaker, not supposed to talk about any weaknesses, concerns, worries. Us helping to normalize that and destigmatize kind of the mental health side of things really went a long way.
Good question.
Yeah, thank you for that question. That was good. And interestingly, it's actually moved toward now the hospital administration has hired a full-time psychologist who's technically a part of our team, but who is dedicated to physician wellness. So that wasn't a thing before, and now it is.
It's pretty cool. Yeah.
Yeah,
Who takes care of the people who take care of people.
exactly.
You get really meta and go, who takes care of the people that take care of the people that take care of the people. But
I just saw an article come up across probably on LinkedIn or something today or yesterday. It says something about like psychologists. We're asking you to share your own mental health challenges because we think basically that it's setting the stage for the role model that we need right now to really address stigma. My response to that is we're just as human as everyone else.
Right.
Yeah.
Even last questions or comments? Wow. So I don't know if you had any other kind of parting words or anything, Cori, but I'm not gonna keep you and force you for another 15 minutes. But
No, that's okay.
it's nice to hear different perspectives. So I for one I really appreciate it because I think it's something you can't get from a single person. You certainly can't get from reading a book. And if I ever am able to return the favor with any of you guys, I'm always happy to. I don't know what specialty I could possibly talk about though.
Yeah.
The role of Spider-Man in psychology, I don't know.
That's awesome.
I really do appreciate
Yeah, no, for sure. No, I think the only thing that's kind of really exciting about this time in the world of psychology in general, not just health psych, is that and I've said this recently, that if we were having this conversation 10 years ago, and you looked at the job opportunities for health psychologists in our country, you would see few. Like I'm on a listserv with the Society of Behavioral Med where I get this weekly email that's, job opportunities. You'd see like, 1 or 2 a week, maybe. Now there are like 30 opportunities weekly across the country for really awesome positions. And they're really specified, like cancer prevention and control, tobacco cessation, they're all kind of, or trauma psychology, or, the field has grown so much in the last, 20 years, but certainly the last decade to the point where the opportunities are robust. And similarly, now that I work in industry in the digital health, digital tech space, it's really interesting. It's 10 years ago at my professional conference, I didn't meet anyone who worked in industry. I didn't know, how to apply behavioral science to like apps. And now 2 of my former students work for different apps. One works for Weight Watchers, one works for Noom, another one works for Calm, that like really wicked cool app. And I work for a software, behavioral health software company. And I just sat on a panel a couple of weeks ago at a conference with other folks who work in industry. And I would say that the room was standing room only with students who were interested in learning about working in industry and what can psychologists do in the tech world. And it's a thing now, and it wasn't a thing 10 years ago. So it's really exciting. There's so much you can do.
It really is. No, I think that's pretty cool that you have branched out into that. And now that I think about it, I'll have to take up that part of the conversation offline with you because I'm actually doing something with probably a similar company to yours and wondering if maybe I could help you
Neat.
in some way because it's training for people that buy the software, but it's mental health related software. So.
Oh, neat. Okay, let's talk.
Okay, well, thank you again, and
For sure, it's a pleasure.
yes, and then until later, we'll chat later.
Sounds good. Thanks, guys. Nice spending time with you. Hope you have a good afternoon.
Thanks.
Yeah, thanks, Jeff. Bye.
Bye. And for everybody, so I still never got an actual answer on the time for Thursday, whether I'm allowed to do 12:30, but what I think I could do is I'm going to make the executive call and say, let's just do the same time, 12:30. And if we have a room, if our room is available, great. And if not, what we're doing can happen pretty much anywhere. We could go sit outside and do it. So let's just do 12:30 so that way everybody could be there. Everybody here is good at 12:30, right? Except for like Zoom wise, I'll figure that out. But yeah, so we'll do 12:30 like usual, and then Thursday will be our last get together. You guys can hit the road.